Hey everyone, and welcome to our video on developmental anatomy of the gut. So we're going to more or less split our sort of GIT anatomy coverage between this week and next week, at least in terms of the in-depth stuff. So this week, you've hopefully already watched the overview of the GIT that Deepak put out. I'm going to be covering the embryology and how that turns into both congenital abnormalities when things go wrong, and also just the normal anatomy of the gut when things go right. And how that has implications for the spaces of the gut and also for the neurovasculature of the gut. Next week, we're going to be bringing out a video on the actual organs of the gut, common pathologies of diseases relating to those organs, and also the neurovasculature. Yeah, let's get into it. All right, so the gut tube is basically, if you look on the right there, a tube which originates in the embryo, okay? So the main formation of the main adult expression of the gut tube is the digestive system, obviously. So all the way from your esophagus down to the anus, the gut tube is basically the progenitor of everything that happens in the GIT system. Now, something that is not on these two big diagrams, which very nicely and neatly present everything, are the pharynx, the thyroid, and the lungs. So the lungs are probably the biggest thing, apart from the GIT, that develops in the gut tube. And that's actually, if you think about it, a lot of the reason why we have one common opening, if you think up to the pharynx, which is just a bit behind your mouth, why we have just one opening for both your respiratory system and your gastrointestinal system, which seems kind of weird otherwise. So yeah. Almost all of in fact, all of the organs of the GIT form from some part of the gut tube, but the way that they get there can be very different. So most of the embryology that we talk about with the gut tube is not actually about how things grow, it's more about how they move. So there's a lot of rotation and a lot of development and growth that occurs in the changing shape of the gut tube over time as we get to adult anatomy, basically. Okay, probably the biggest implication that I want you to have a look at right now is that we have three main arteries that supply the gut. Okay, so you've got the celiac trunk up the top, you have the superior mesenteric artery, and then you've got the inferior mesenteric artery. So if we think about the gut in three sections, the foregut, the midgut, and the hindgut, they're basically demarcated by what's supplied by each part of the each one of those arterial trunks, and they all come off the aorta, obviously. Okay. And that's sort of the major, probably one of the biggest adult expressions of this embryological origin. Okay, so there's basically, they give you a whole bunch of stuff about embryology. It's really confusing. There's a lot of it. You don't need to know most of it, okay? So the important thing to understand is basically, if you look at this diagram, you can see how we start with a embryo, which is sort of two sacs and a little bit in the middle. And then the top sac goes and folds over, and in doing so, it creates the abdominal cavity and the gut tube inside it. So basically, the takeaway I want you guys to take from this is that the abdomen is a sac of mesoderm, okay, that middle sort of layer of the embryo. It's a sac of mesoderm where the outside is parietal mesoderm and the inside is visceral mesoderm. If you remember respiratory anatomy, this should be a bit familiar. So the parietals on the outside, the viscerals on the inside, they're only connected at the back, basically, or at least they're only the major connection with all the neurovasculature is the dorsal mesentery, which is again part of mesoderm, but not part of either the visceral or parietal. It's all covered by the ectoderm, which then becomes like your skin, basically. And then the actual inside of the gut, which goes on to form both the epithelium and like the lining of the gut itself. And then a lot of the gut organs are all made of endoderm, basically. So if we think about it in layers, it goes ectoderm, parietal mesoderm, then the connectional dorsal mesentery to the visceral mesoderm, and then finally the endoderm on the very inside. And you can think of the gut as a tube of visceral mesoderm, which is lined by endoderm, basically. Okay, that was a whole lot of words. Basically, just look at the third slide in this diagram, sorry, the third image in this diagram, and that's all you really need to know, because that pretty much sums up how things happen, both in terms of A, that the gut is this big tube, and that we have two layers of peritoneum, which are made of the same essential substance, and then two, most of the connection in terms of the rest of the body and all your supply of various things comes from the dorsal mesentery. Okay, Now, sometimes, little note, we call the parietal mesoderm the somatic mesoderm, and the visceral the splanchnic mesoderm. That's not particularly important, but it is good to know if it comes up somewhere. I'm going to have a few slides with little asterisks here. These are basically reference slides. It's just a whole bunch of information to dump on you. So I'm not going to talk about them much in the video because there's not much point. I'd just be reading off it. If there's important stuff, I'll point it up. Otherwise, they're sort of just sitting there in the slides to help you if you need a reference. Okay. So the foregut, that's our first part. It's supplied by the celiac trunk, if you remember. It has all of those little organs up the top in it as the adult form, okay? So it starts off very neatly. So if you remember in the embryology thing, everything was super neat, right? We had one little gut tube in the middle and then the dorsal mesentery. That diagram didn't show the ventral mesentery, which then eventually forms. And you can see here, once we get a little bit further in embryological development, we end up having the aorta at the back, a little bit of dorsal mesentery, the main tube. So your stomach is the main tube of the gut. If you think about it, although the liver is sort of technically part of the gastrointestinal system, it is not actually part of the main channel. Like food never goes through your liver. So the stomach is the bit of the foregut, which is actually the middle. So everything behind the stomach or close to your spine is going to be dorsal mesentery. Everything in front of your stomach is going to be called ventral mesentery, okay? So we started with a pretty nice little line here. Basically, it goes from your aorta to your stomach to your liver. And then on the next slide, you can actually see some of the other smaller organs involved here. It's basically aorta, your spleen, so your pancreas, your spleen, your stomach, and then your liver. But the big problem here is that your liver needs to grow, and it doesn't really grow symmetrically across the front of your stomach. It actually ends up moving to the right. So because the liver has gone right, everything else gets pulled left, basically. Okay, so your stomach still stays kind of in the middle, but it is now going to be tilted it's going to point right, because the front of it almost, if you think of it like sort of a kidney bean, so the smaller side of it, the C-shaped side, they're both C-shaped, the smaller side of it is going to be pointing at the liver, and because the liver goes right, that has to point right towards the liver. The bigger side of it then points left, okay? And that's the gastrolineal ligament there, also known as the gastrosplenic ligament, because it goes to the spleen. And the poor spleen this all used to be in a straight line before we even get to the diagram on the left. The spleen has now gone all the way to the left, okay, because of that. And yeah, the other part of that is that the liver is actually above the stomach. So the stomach is actually going to tilt upwards as well in order to stay pointing in the smaller side at the liver while being pushed around by it, basically. Okay. Now, a concept I want to get across here, because it's sort of a confusing one, and I think it's usually because it's explained in more detail and more abstractly than most people need, is the concept of intra versus retroperitoneal. So these are two terms that you're going to hear to describe organs, and what they actually mean is actually quite simple when you get down to it. So intraperitoneal, okay, so if you look at this blue bit here, right, so we got this whole big cavity, that's the peritoneal cavity, which is basically just your abdominal cavity, okay? That's where all the cool kids hang out, okay? Everything inside the peritoneum is called intraperitoneum, okay? So your liver's over here, your stomach's over here, your spleen's over here. Now, your kidney and your aorta start outside the peritoneum, okay? So they are what we call retroperitoneal, so retro behind peritoneum, okay? Now, if you notice, the pancreas actually starts in the peritoneum, but then it gets shoved out. And by the end, it's outside the peritoneum, okay? That is what we call secondarily retroperitoneal. So if it started inside, but it got kicked out, it's called secondarily retroperitoneal. And literally the entire definition of intra versus retroperitoneal, you'll hear like it has mesentery on the anterior side. Literally all that means, because remember the mesentery is sort of the same substance as the coating of the abdomen in the first place. All that means is that it's outside this peritoneal cavity. So if you scooped out everything in the peritoneal cavity, because it's still behind that wall, it won't get scooped out. Okay, it's outside. That is literally all it is. So don't like overthink it, basically. Okay. Yeah. Now the other thing I want to mention here is that we have. I'll probably mention in the next slide because that's a better diagram. But we have two things called the greater and lesser omentum, and it's basically just a way of describing the bits of mesentery, so that midline that we've got connecting the whole little chain here, that connect to the stomach. So the bit that starts in front of the stomach, so anterior, closer to your belly button, you can see there it's labeled as the lesser omentum. The bit that starts behind the stomach, closer to your spine, is called well, it's not labeled, but it's called the greater omentum, basically. Okay, so the gastroiliacal ligament forms one of the very side bit of it. Okay, we'll talk a bit more about that later, but for now, can you see how it sort of divides the cavity into two bits? So there's one bit behind the stomach, and there's one bit in front of the stomach. Basically, we're going to talk about the spaces later, and you'll see that the bit behind the stomach is called the lesser sac, and the bit in front of the stomach is called the greater sac. The only reason I mention it now is because it's important to understand it both side on and top down, because it looks very different. And I think you can only really understand it in a 3D sense if you see both views. So remember, the back is the lesser sac, also known as the mental bursa, and the front is the greater sac. Okay. This is basically what I was talking about before with the stomach. So we start facing forward, and then the liver, goes off to the right, so the stomach has to turn to face it, and then the liver goes up, stomach has to turn to face it again, and it ends up pointing both rightwards and upwards from our original, very nice and straightforward position. Okay, yeah. So the greater curvature is where the greater omentum attaches, go figure, and the lesser curvature is where the lesser omentum attaches. Okay, so this is a lot of words, don't worry, it's not too complicated. So the pancreas basically starts as two bits. So if you look at the diagram here, the green bits are the main, the purely biliary system. So the green little tendrils here are going to form the liver eventually, and that green bit there is your gallbladder. Now the pancreas is both this red bulb at the front and the dorsal pancreas, which looks sort of like a leaf at the back, okay? So the pancreas is going to need to join together, right? It can't just stay in two parts. So what usually happens is it swings around the backside, or the ventral pancreas swings around the backside and joins up with the dorsal pancreas, okay? And it fuses into one structure. Now, what happens if that fails to happen properly, or if you basically it tries to swing around and it kind of joins, but not all of it goes around to the back, some of it sticks around to the front. You can have what we call an annular pancreas, which basically means there's pancreas all around the intestine, which is bad because we want it to just be on one side of the intestine. And we can end up having it sort of compress the intestine, and that ends up, you have abdominal distension because stuff is getting stuck there. You have emesis of vomiting, and you can have general digestive issues because things aren't getting through because the pancreas, instead of being off to one side, is pressing in from all sides on the intestine. Okay. And then the other little tidbit is that while we're all doing all this swinging around and growing, the tail of the pancreas sort of sneaks out, and it pops out of the splenorenal ligament between the spleen and the kidneys, and then because, like we said, anything that sneaks into the peritoneum, the actual abdominal cavity becomes intraperitoneal. Because it's snuck back in, it avoids being banished into secondarily retroperitoneal, and instead it goes back to being intraperitoneal. Okay. All right, another reference slide. Not much to say about this one. I've covered pretty much all of it. There are a couple sort of mnemonics to remember which bits are intra and retroperitoneal. I think the important things to remember are basically that your urinary system and your blood stuff, your aorta and your IVC, are all behind. They're all retroperitoneal because they had never had anything to do with the gut in the first place. Now, your gut is going to be basically mostly intraperitoneal, with one exception being parts of the duodenum, until you get down to your cecum, which is like the very first bit of your colon, or your large intestine. And then from there, it alternates. So your colon, your cecum starts off intra, then ascending, retro, and then your transverse, back to intra, your descending, back to retro, and then your sigmoid, back to intra, and then finally your anus, your rectum and your anus, which are then back to retro, because they leave the abdominal cavity in order to reach the exterior, obviously. Okay. Yeah, so this is the adult foregut. So, we did our whole little song and dance, and now we have adult foregut with the stomach pointing to the right and up. Your pancreas is tucked away behind it. Now, I want to point out, we've got the lesser omentum. It's mostly been cut away, but you can kind of see a little bit left in a little U shape down here. That's on the small, lesser curvature of the stomach. You've got your greater omentum, which is all draped over here. You can see it attaches to the greater curvature of the stomach, and then it sort of goes over the transverse colon right here. And we'll talk about exactly like the fact that it actually is draped over that. That's not just how it looks in the next slide. And then, of course, you got your spleen hanging out here, and your kidneys, as you can see, firmly outside our peritoneal cavity. Okay. Now, on the right, we have this thing called the Pringle maneuver, which is just funny, honestly. And basically, okay, the actual procedure is not funny. What happens is there's a little ligament, which you can kind of see, again, cut off in the left side diagram, but that's called the hepatoduodenal ligament. And so it goes between the duodenum and the liver, and it carries the portal vein, which is the main venous drainage for your abdomen, your proper hepatic artery, which is the main arterial supply for your liver, and then the common bile duct, which carries bile from the liver and from the gallbladder, okay? 3 really important structures. Now, during surgery, as you can see in the diagram to the right, we basically just clamp that, and that's what we call the Pringle maneuver. We're just clamping that ligament in order to stop those blood vessels from flowing, because it means that we get less bleeding from the liver if we need to do something around that area, basically. So let's talk about spaces in the abdomen. So I've already talked about the whole thing, which is the peritoneal cavity, and I've also touched on the idea of the greater and lesser sac. So the greater is everything in front of the greater and lesser omentum, and all of that little bit of mesentery that connects together, which is the red and yellow bits in the diagram below. That's all greater sac. The blue is the lesser omentum, or lesser sac. Sorry, the lesser sac, also known as the omental bursa. Okay, so it's important to note that a lot of these spaces are not separate, so they're not actually physically separate. They are just, like, you can actually have holes between them where stuff can move, but they're just considered differently because there's a large amount of separation between them. Okay, so there is a channel between the greater and lesser sacs, which is sort of behind that hepatoduodenal ligament that we talked about just before, and that's called the epiploic foramen of Winslow. Okay. We also have the supracolic and infracolic compartments of the greater sac, and the sort of boundary for those is the transverse colon and the mesentery attached to it. That's not super important. What is important is that you have the right and left paracolic gutters, which are bits which are lateral, so to the sides of your abdomen, where infection can travel. So that actually does come up in exam questions. So keep in mind where they are and what they connect and why they're important. Okay. And then the bottom part of the peritoneal cavity is actually quite important because it's where fluid pools when you stand up. So if there's fluid in the stomach, this is where it will collect in a patient who's standing, which is the normal way that they present to you. So it's slightly different between men and women, basically. So the diagram shown here is of a female patient. So in a female patient, the lowest part is the recto-uterine pouch, because basically the thing that is closest to the rectum is the uterus. Okay. Now, male patients do not have uteruses, and so the thing closest to the rectum is instead the bladder, which when you hear vesicle, it just means bladder. Okay, with an AL, not an LE. That's a cell thing. So in men we have the rectovesical pouch. In the women we have the recto-uterine pouch. Okay. Now, coming back to the greater and lesser omentum, I mentioned how it's like actually draped. Basically, it's because we mentioned before the lesser omentum, which is the stuff that used to be in front and is now right and upwards. That's just hanging out there. The greater omentum used to be back and it's now down and to the left, but it sort of grows quite quickly. And in doing so, it drapes itself over the transverse colon. And because things, when you're growing, are very sticky and they can sort of develop if they stick to things, that's exactly what happens here. So your greater omentum starts just sort of flopping over that, and then it actually connects and turns into one structure. So there's actually 4 layers of mesentery in that colon, because it starts with double layers to begin with, and then we double on in, it doubles over on itself to form 4 layers in that little thick bit that you can see there. Okay. This is another good diagram. It's just to illustrate that even though in a lot of other sort of abstract diagrams, we only show a couple little bits of the intestines basically, but they're actually heaps. And this is what is more likely to actually look like in the patient, okay? Yeah. Shunts, another little sort of quick reference slide. So basically these are bits of the embryological circulation where we bypass the liver. So your lungs do not work when you're in the womb because there's no oxygen, and your liver does not work yet either because your the mother's body is going to do all of the filtering for the embryo basically. Okay, so we have these shunts in order to let blood just go straight from one side of the organ to the other without having to actually go through the organ because it wouldn't do anything. Okay. And so those things then turn into, they get what we call obliterated, which is basically a very fancy word, but all it means is that we had something which used to be a tube in the embryo, and then in the adult it becomes connective tissue, like a ligament or something. And if things fail to obliterate, we can have problems, which we will cover in when we talk about the midgut and the hindgut, actually. This is, again, a reference slide. I'm not going to read it out because it's basically just stuff you need to learn. Another interesting thing is that the round ligament of the liver is also a remnant. So it used to be the umbilical vein, which goes to your umbilicus and to your placenta. But because it doesn't bypass any organs, it just goes from the placenta to the embryo, it's not considered a shunt. But it is meant to get obliterated and turn into the round ligament. Okay. All right, so the midgut rotation, it's a little bit more complex. It's not that much more complex, okay? So I think people also overthink this one. Basically, and I'm going to basically explain it in the only stuff you need to know first, and then I'll go into a little bit more detail if you care about it, okay? So the stuff you need to understand is that we start with sort of a little U shape, and it's vertical. So there's the top loop directly on top of the bottom loop, and then they flip, okay? So the top is now at the bottom, okay? And then they just grow. That's basically all you need to understand. So that's why, even though the colon is the back part of the gut, because it comes, when food goes through, it goes through the small intestine much earlier than the colon. It's actually physically above a lot of the small intestine. That's it. Okay, because the small intestine started on the top and then it gets flipped over during development and it just stays there. Okay, as it grows into all of these little twists and turns. Okay, now in terms of congenital abnormalities that can happen, in terms of rarer stuff, we can get on fatter cell, which is basically these loops, when they stuck out through the umbilicus, so they sort of leave the main body of the fetus and they stick out through the umbilicus, the umbilical cord. If they don't come back in, then we can get emphaticele, which is where they sort of stay in the umbilicus, and you get an umbilical cord, which is sort of transparent, and you can see intestines inside, which is really weird. In gastrochises, which is sort of a weird one, but basically they herniate through the abdominal wall near the umbilicus. Okay, you don't need to understand too much about it, just the difference between them is good. Now, you can also see the vitelline duct, which is a little sort of sticky out bit at the end of the purple bit here, which is what we call the cranial loop. And that's meant to come back in, basically. So that's not your appendix. Your appendix forms from your colon, and specifically the cecum. That's meant to come back in. If it doesn't come back in, we get a thing called Meckel's diverticulum. And we'll talk about that a little bit more on the next slide. So now for the more detailed explanation. So when we start with those, the midgut, where it starts there with a sort of very vertical position, we have a cranial loop on top, which is the purple, and we have a caudal loop on the bottom, which is green. Caudal just means tail, so you can be like head and tail, basically. So what actually drives this sort of flip over is that the cranial loop grows much quicker than the caudal loop, because, as you can imagine, the small intestine ends up being a lot longer, so we need to do a lot more growing to get there. And because there's not space up above, it ends up getting flipped. Okay, and it grows into the space underneath. And then things are sort of vertical right now. And then I don't know if this is going to turn out the right way because of how Zoom recording works, but basically your cranial loop then flops over to the right, which forms your duodenum. And that's why your duodenum sort of, if you think of your stomach exit, it curves to the right before it comes back the other way. And your caudal sticks to your left, which is why your transverse colon comes around that way. Okay, so you can see that in the diagram. The bit 3 there is basically a really good representation of how that happens. And that's basically why we have this sort of weird convoluted shape to the intestines in adulthood. Okay, and you'll notice between 3 and 4 there, the cecum actually grows down. So even though we call it the ascending colon, and that just refers to the fact that stuff ascends up it when it's being digested, it actually grows down from the top, so your right upper quadrant region of your abdomen, down to the very bottom. Okay, very rarely you get undescended cecums, and which is why your appendix can sometimes be in different places, but it's not really a common thing. Okay. Also, if we're talking about more detailed stuff, you'll notice that the sort of ends of these little 2 loops actually stay in similar locations. So you notice if you look at part 3, you can see the end of the purple loop and what used to be the end of the green loop are actually very close. And that is true in the adulthood. So the duodenum, and specifically the ligament of Treitz, which is between the diaphragm and the duodenum, is very close to the phrenocollic ligament, which is between the diaphragm and the colon. Both very well. Ligament of Treitz is not greatly named, but the second one is. And basically those attach to the duodenum and the transverse colon, which are very far apart if you go through the actual length of the intestines, but they're very close together if you talk about where they are in terms of physical distance. And that's because they're both stuck right next to each other while this whole folding process is going on. So they're stuck there to the abdominal wall and they anchor everything in place. So even though it's all growing in sort of crazy directions, those 2 bits stay in the same place. And so everything is still connected. And that's why it sort of comes back up to pass over the same area. Okay. Hopefully that made sense. Okay. So this is talking about omphalocele. Ooh, I pronounced that wrong. And gastrochysis. Okay. Sorry, I think I pronounced both of those wrong, but you get the idea. Then this is Meckel's diverticulum. So there's something that we call the rule of 2s, which is basically Meckel's diverticulum, usually 2 inches long, usually affects 2% of the population, and it's 2 feet away from the cecum. Okay, so you have this is in the ileum, and then if you go another 2 feet along, you reach the cecum. Okay. Little point about omphalocele and gastrochysis is, I think that's the correct pronunciation, is that other organs can actually herniate. So usually just the intestines, but there's no reason that other organs can't also herniate in the same way. But these are both really rare. Meckel's diverticulum is comparatively really, really common, but the other 2 are quite rare. In terms of symptoms for Meckel's, most people will be asymptomatic, so like you'll never actually notice that you have it. But some people, like when they do have symptoms, usually they'll have hematochezia, which is blood in your stool, basically. There's no pain involved. And then you'll also have obstruction, so stuff feels like it doesn't get all the way through, basically. Okay, because it gets stuck in this diverticulum. So instead of going nicely out where it gets excreted, it's just sort of hanging around in there, which is not fun. Okay, so the hindgut is actually almost the easiest part, because all it is you originally have one hole which connects to 2 tubes, one of them being the urinary tract in the embryo, and the other one being the digestive tract. And then you need to split it into 2 holes, okay, because otherwise you'd have 1 hole. And as we will find out, that's quite bad. Okay, so the bit that grows between them is called the urorectal septum, and it becomes the perineum, which is the area between the genital region and the anus in the adult anatomy, basically. So you can see how it sort of grows outwards. So it starts inside, which is why we have 1 hole to begin with, and then it grows outside. Now, because we were only really looking at the anus here because we're dealing with the GIT, it's important to note that the anus both grows from the outside in and from the inside out. So it's like 2, I guess, like 2 teams of laying train tracks, like one moving in from the coast, the outside of the embryo, and the other one moving outwards. Okay, so it doesn't actually, like, they don't meet at the very outside, they meet slightly inside, and that's going to have implications that we'll explore a little bit later. Okay, so yeah, it's bad if this whole process doesn't happen properly. And here's what happens if you don't. So imperforate anus is when you don't properly have that little, those 2 tunneling teams joined together, which is very bad because you can't excrete stuff. I'm not going to go through all of these because they're all exceedingly rare, and most of the problems are pretty similar, but they're all not very fun for the patient, but they're interesting. Okay, so the pectin line, this is what we were talking about. So you can imagine like the outside tissue starts growing inwards and the inside tissue, the gut tube, continues growing outwards, okay? So the bit where they meet is called the pectinate line. So because they come from completely different locations, the outside being sort of the exterior of the embryo and the inside being obviously the developing gut tube, the nervous supply, the vascular supply is going to be completely different between the two, and that becomes quite important. Now, the most important clinical manifestation of this is the fact that if you get hemorrhoids, which are sort of just little aberrations in the very distal end of your GI tube, they can be very painful if they're below the pectinate line, because we have somatic motor and sensory innervation, which is much more your body pays attention to, whereas above the pectinate line, you get visceral sensory information, okay, which your body doesn't pay as much attention to, basically. So you get somebody who has hemorrhoids above the pectinate line, it's like, oh, I have hemorrhoids. Somebody below the pectinate line will know that they have hemorrhoids because it hurts a lot, okay? One thing that's not mentioned on this diagram is that the epithelium is different between above and below the pectinate line. So above it, we have columnar epithelium, as with most of the gut, and then below we have stratified squamous, like the rest of the skin. Go figure. Okay, last little bit here, which is talking about the neurovascular implications. So really, it should just be the nerves and the arteries. The veins, as we're going to find out, don't really correspond particularly well, but the nerves and arteries really do. So we've already talked about the arteries, and they work really well. This diagram on the left side is basically all you need to know about the GI arterial supply. It all boils down to, or almost entirely, boils down to those three trunks. So the celiac trunk, the SMA, and the IMA, which supply the foregut, midgut, and hindgut, respectively. And in terms of the nervous supply, so we have a bunch of different nerves. Ignore the least splanchnic nerve there, because that basically has no interaction with the rest, and that's just for your urinary system, which is not related here. Remember, your urinary system is actually completely independent of your gastrointestinal system, okay? All of the stuff in your pee comes from your blood. All of the stuff in your poo comes from the food that you ingested, okay? It's not like there's a little sorting center where you separate out like fluid stuff and solid stuff. They're completely separate systems, okay? But we then have to talk about the greater splanchnic nerve, which is the foregut, which is basically mostly supplying the foregut. The lesser splanchnic nerve, which sort of cheats a bit because it steals stuff from the greater and the lumbar I can't pronounce that word, splanchnic nerve, to supply the midgut. And then the lumbar splanchnic is what supplies the hindgut. Okay. Now we have what we call periarterial plexuses, which is basically, if you follow all of the nerves that supply these things, they'll all meet at the arteries. Okay. And this is where the sympathetic nerves are going to have their little, are going to synapse, basically. Okay. So you remember sympathetic nerves, they synapse at ganglions instead of in the at the organ, like parasympathetic nerves. So where this happens is going to be at these periarterial plexuses, which correspond perfectly to the arteries which supply these organs. So it's actually really nice and neat in that respect. And of course, looking back to that pectinate line, you can see how it is actually a completely different nerve, which does the supplying for the inferior rectum, the inferior rectal nerve, which is somatic sensory afferent. Okay. Now, final thing, bit of a sad note to end on, venous drainage does not really correspond to embryology, so you can't use that nice sort of clean differentiation to explain the veins. But yeah, so in summary, you can really see how that sort of three-sided development shows up in the neurovascular structure, and you can see how the movements in the gut tube as your embryo sort of grows and matures is actually represented in or reflected in your adult anatomy. So hopefully that helps. Feel free to send me any questions as always, and have a good day.